All right, started recording. Good morning, everyone, and thank you for attending our Grand Rounds lecture. I'm pleased to introduce to you our speaker, Dr. Hundley, who's presenting on cardiovascular magnetic resonance imaging, forecasting on sudden cardiac death in cardiomyopathies. Dr. Greg Hundley is a proud alumnus of VCU School of Medicine and the first director of the Pauley Heart Center. His expertise in preventive heart care and his research in cardio-oncology has built our strengths in the Pauley Heart Center and the VCU Massey Cancer Center. His research focuses on preventive heart care for patients undergoing chemotherapy, which has been found to increase the risk of heart attack and other cardiovascular issues a decade or more after treatment. He was the first in the world to use MRI to visualize and measure myocardial blood flow, and the first to demonstrate that MRI stress testing can identify those at risk of heart attack. Dr. Hundley came to VCU Health from Wake Forest School of Medicine, where he served in several roles over the past 22 years. Most recently, he was the medical director of the Reynolds Tower Cardiovascular Imaging Facility. He currently serves as a member of the ACC Integrated Learning Committee. He's a Cardiovascular Imaging Committee and ACC Imaging Network. He's also a fellow of the American College of Cardiology and the American College of Physicians. He's a member of the Clinical Cardiology Council and the Cardiovascular Radiology Council of the AHA. He's also a member of the Society of Cardiovascular Magnetic Resonance in Medicine. In conjunction with Dr. Hundley's arrival, a new cardiovascular imaging suite, which opened to patients in July 2018, brings together personalized and cardiovascular evaluation in the diagnosis and treatment at both Pauley and Massey patients. Dr. Hundley and Dr. Robert Wynn, the director of the VCU Massey Cancer Center, work closely together to identify and understand the connection between oncology treatments and cardiovascular events for patients. We are very grateful for Dr. Hundley's expertise on this topic and look forward to learning from him. At the end of this lecture, we will leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. We are also pleased to offer both CME and MOC credit for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and at the end of the presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Winston. I will now turn it over to Dr. Hundley. Thank you, Dr. Hundley.
Oh, no, thank you, Rahul. Really appreciate the introduction and look forward to chatting with everyone here over the next hour and think a little bit about cardiovascular magnetic resonance and forecasting sudden death across really a range of cardiomyopathies. And so these are my disclosures, and this is an outline for the talk today. We'll discuss the use of cardiovascular magnetic resonance for assessment of left and right ventricular function. We'll discuss the incorporation of gadolinium in CMR to characterize myocardial tissue and forecast cardiovascular risk in ischemic heart disease. And then we'll switch and we'll talk about that same gadolinium and how it might identify prognosis in non-ischemic heart disease. Then we hear a lot about mapping. Well, what is that? And so we'll review some newer CMR mapping methods for further characterizing myocardial tissue and forecasting prognosis. And then we'll discuss the use of CMR in those with implanted devices. And we'll finish up with summary and questions. So this first slide highlights the acquisition of what we call cine images, or really movies of heart motion. And in the top left is a two-chamber view. And so here's the left atrium, the left ventricular cavity, and down in the bottom left is a four-chamber view. So we have the right atrium, the right ventricle, the left atrium, and the left ventricle. In these images, there's no contrast administered. The moving blood provides its own contrast. And you can see that the heart muscle appears dark gray. And generally, the heart muscle is thicker toward the base at the annulus of the mitral valve for the left ventricle, and then it tapers as we move toward the apex. Over here on the right are cine images of abnormal LV function. So again, another two-chamber view. So left atrium, excuse me, and left ventricle. And notice out here in the distal segment of the anterior wall of the left ventricle, there's virtual akinesis. And then we switch down here to a four-chamber view, And we see in the distal segment of the anterolateral wall akinesis. So this is a very robust method for evaluating regional LV wall motion. Now, how do we score LV regional wall motion? Well, it's exactly like what we do with transthoracic echocardiography. We do obtain 3 apical views, so a 2-chamber, a 4-chamber, and I have here long axis. We call this an MR a 3-chamber because we have the aortic, the aorta and the outflow tract listed here, but it's equivalent to a parasternal long axis. And then we will make some slices across at the base, in the mid, and in the distal segments shown down here to have a basal, middle, and apical short axis. These are cine images of, again, the 4-chamber and the short axis on the right. And then what we do is we score wall motion as normal. It can be hyperkinetic, so it's contracting too vigorously, but then it can be hypokinetic. It still contracts, but not to the same degree as normal. It can be akinetic, it doesn't contract at all. It can be dyskinetic, where it kind of bulges outward, where the other walls are contracting. There's actually no contractility at all, and the wall bulges the other way. Or it can be discordant. And a lot of times you'll hear about discordant contractility when we think about paradoxical septal motion during transthoracic echo. And when you're looking at reports, generally the SCMR recommends we use sort of this 17-segment model, and it's down here at the bottom right. And it's like you're looking at the end of an American football. And so this is the distal or apex right here in the center, and then you're moving back toward the laces. And so you have the distal segments here, the middle segments, and then the basal segments circulating all around that circumference. So regional wall motion can be very helpful. This is just sort of a 4-chamber view up here in the top right. So again, right atrium, right ventricle, left atrium, left ventricle. And you can see that this particular segment of the wall is not compacted. It's non-compacted. The fibrils are out in the ventricular chamber. And so a very nice method for visualizing morphology and evaluating regional wall motion. Over here is a coronal view. This is a view that's very common in chest CT. You are able to appreciate the LV cavity, but also its relationship with the aortic valve and the aorta. So the point is we can evaluate regional wall motion, but very nicely we can organize planes of imaging of the heart and surrounding structure in virtually any orientation. Now, another process or disease process that we can evaluate looking at this regional wall motion is something called mitral annular disjunction. And mitral annulus disjunction is an abnormal atrial displacement of the mitral valve leaflet hinge point. So I want to look down here at these 2 pictures. So here's a 3-chamber view. So here's the aorta, the left atrium, the LV cavity, and look at the wall of the left ventricle. So it's coming back thick, 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 and it stops here. But here is the mitral annulus. You have just this little thin rim of tissue. And as many of you know, that is associated, just this anatomic finding is associated with sudden death. And so a very nice study was performed in Oslo, Norway, to really evaluate this when you find it, and what's the risk of experiencing ventricular tachycardia or ventricular fibrillation? Well, a couple things. One, it's much less likely to be associated with sudden death if mitral valve prolapse is also present. And that's highlighted over here. And so these are patients in which there is mitral valve prolapse. So many do not experience sudden death. But when they do not have mitral valve prolapse, there is a much greater risk of experiencing sudden death. Other factors that associate with sudden death are the length of the disjunction. And so this length of this little segment right here, and certainly when you get above 1 centimeter, everyone would agree that's very high risk. And there's some sort of concern from 7 to 10 millimeters. And then, but below 7 millimeters, not so much an association with future sudden death. And then another factor that is associated with sudden death is if there's the presence of concomitant papillary muscle fibrosis. And so we'll show some examples of fibrosis a little bit later here in the talk. Now, another thing that we can do with this cine imaging is measure left ventricular volumes, ejection fraction, and mass. And how do we do that? Well, we collect a series of these short axis images, and you can see them over here, starting at the base and moving all the way out to the apex. And sort of picture, I don't know if you can see my image here, but this is one of these bottles of tea. And what you're doing is you're getting slices starting at the base and working all the way up to the apex. And if you trace the area of each slice and you know the thickness, very accurately, you can calculate the left ventricular volumes and the ejection fraction. And because you can appreciate also the epicardial surface, you can identify the myocardial volume, and using a multiplier, calculate myocardial mass. So it's a very accurate technique, and it's approved for use across all of these conditions when you are referring someone for a CMR study. Now, when you're evaluating and reporting left ventricular ejection fraction, I do think it's always relevant to think about the left ventricular volumes. And this was a study by Giselle Melendez back in 2017. So it highlights up here in a cartoon this particular point. So these are patients, this study focused on patients that are receiving potentially cardiotoxic chemotherapy for treatment primarily of breast cancer, but also lymphoma. So how do we calculate ejection fraction? So we take the end diastolic volume, and here's a nice example, 100 mLs, and we take the end systolic volume, we subtract the two. So 100 minus 40 is 60. We divide by the end diastolic volume of 100 and we get 60%. Well, we're usually looking for situations where the ejection fraction may fall, in this example, to 52% because the end systolic volume has increased. And that is due to generally contractile dysfunction. But one can also experience a similar decline in ejection fraction to 52% if the end diastolic volume falls. And so this was a study of 112 individuals, and 26 participants experienced large declines in EF to absolute values less than 50%. And it was evaluating in those individuals that experienced a decline in EF, what did so as appreciating an increase in end systolic volume, so that's over here in orange, or simply a decrease in end diastolic volume. I mean, cancer patients have poor PO intake, or they may experience nausea or vomiting or even diarrhea, and 20% did so just because of a change in end diastolic volume. So one thing that's nice with this MR technique, but also if we're performing echocardiography or if we're in the cath lab, we always want to interpret an EF change in the context of a change in ventricular volumes. One last thing about sort of the cine wall motion. If you ever have a situation where you're thinking about the right ventricle and the right ventricular outflow tract, remember for echocardiography, that sits right behind the sternum and it's hard to appreciate. Well, with axial imaging and sagittal imaging, you can view this irregularly shaped right ventricle very nicely. And this is just most commonly used in when we have referral cases for right ventricular pathology, for example, arrhythmogenic right ventricular cardiomyopathy. And you can see down here in the cine, here's a patient with ARVC, and you can appreciate the akinesis and the reduced right ventricular systolic function in this disease. Now we're going to switch to tissue characterization. And I do think that's one of the more powerful processes that really are at our disposal when we use MR. And the way I like to think about this is MRI tells you the why. I mean, certainly we might be able to appreciate an abnormality of systolic or even diastolic function, but MR is going to tell us why. And that comes to these principles of tissue characterization. Now, how does the MR work? And we'll be a little more specific later in the talk, but for right now, I want you to know it is imaging, we're primarily imaging protons. And those protons in our body are bound, as shown in this cartoon, to oxygen and water, so H2O, or carbon in fats. Well, we can image, they have different imaging characteristics when we acquire an image in a patient, and that's sort of highlighted here. So here's a patient with a right ventricular cardiomyopathy. The imaging technique has the blood pool now dark instead of white, but you can see the gray associated with the water in the wall of the left ventricle. You can appreciate the carbon-bound hydrogen in the pericardial fat, but look at the fat invading really or replacing portions of the segments of the wall of the right ventricle. So the simplest tissue characterization is distinguishing fat from water, and we can do that with this method. Now, another way we can start to characterize tissue is to administer an agent called gadolinium. Now, unlike maybe the cath lab where we administer ionic contrast and we shoot X-ray images or X-ray beams and we look at the diffraction of that because of that contrast, or maybe we're in the echo lab and we're doing microbubble contrast and we administer these microbubbles and we look at the ultrasound, the effect of those vibrations of those little microbubbles. We're looking at the contrast directly. Gadolinium's not doing that. We're not necessarily imaging the gadolinium per se. What we are imaging is the principle that the gadolinium helps us see water better. Gadolinium helps us see water better. So these are all sort of the hydrogen that are bound to the oxygen and water. And gadolinium, when we administer, it's going to go everywhere in the body, and it's going to help us see that water better. Now, just a couple quick points about administration of gadolinium. Are there allergic reactions? Well, yes, about 1 in 20,000 to 1 in 40,000, depending upon the agent. We always screen for that. It's treated primarily with Benadryl. You'll have patients that will experience a brief metallic taste, and they quickly develop a reflex vomiting. And that occurs in about 1 in 20 to 1 in 40 patients. That is not an allergic reaction. It's just a reflex. There's a little quick spit up in the magnet. Patients know, we rush in there, we give a little one of those little trays, it goes away very quickly. Also want to mention nephrogenic systemic fibrosis. And many of you will remember about 10 to 12 years ago, this is a condition, it causes, the gadolinium accumulates sort of in the skin and causes a scleroderma-like syndrome. And we were very concerned about that many years ago. But with a lot of appropriate measures, using different contrast agents, adjusting doses and things, there really hasn't been a case that I know of worldwide in the last 5 years. And then lastly, there were some concerns about 5 or 6 years ago about brainstem accumulation in cancer patients that had more than 4 double-dose gadolinium contrast studies. And many studies after that. And what was going on in that situation? Folks were looking for metastases in the brain in those with cancer. And what was showing up is some gadolinium accumulation in the brainstem. And there's really been no known effects, and it really hasn't restricted. And we're going to talk a little bit later here about some of the features of gadolinium. And there's been a real push initiated back in 2017 to develop some non-gadolinium contrast equivalents to late gadolinium enhancement. And we'll go over that in a minute, and we'll show some images of that. And I think that's very promising, and we're going to really see that, I think, grab hold here in the next 4 years. So but let's get back to gadolinium because it is used widely. So there's 2 ways we use it. There's 2 ways we use it. The first is the contrast is going everywhere. And so we coordinate the imaging with the first pass, the arrival of the gadolinium water that's come in through our peripheral veins into the heart. And what you see is the gadolinium helps us see water better. And so look at all this gray myocardium. All right. And so that's kind of, it's helping us see the water better. But areas that are subtended, for example, by a stenosis in a coronary artery, you won't have as much of that. And there's dark artifact or dark components to the image. And those are associated with perfusion defects. Now, the next thing we can do with gadolinium is, instead of the first pass, we now wait. We wait 5 to 10 minutes and we take pictures again. And over here is a 4-chamber view. And what you notice is that the normal myocardium, for example, here in the septum, that gets rid of the gadolinium and it appears dark. But areas that have acute water accumulation, so injury or infarction, are going to hold on to that gadolinium. And then also, it kind of gets trapped in areas where there is replacement scar. And so this is late gadolinium enhancement. And this is just sort of an example of the perfusion. You can see down here in the right, the images come up right away. So for example, if you do this during adenosine, and some people even do it during exercise, you get multiple slices of the heart. So here are resting short axis images in this row. You see the perfusion defects by these red arrows here. And then down here, you can sort of see the live image and you can appreciate the perfusion defect. And this is a perfusion defect in the inferior wall of the left ventricle. Now let's get back to the late gadolinium enhancement. And how do we describe it? How do we describe the late gadolinium enhancement? And that was initiated by a gentleman by the name of Ray Kim when he was at Northwestern with Bob Bono. And this is a short axis image of the left ventricle. And you can see this normal myocardium over here in the septum and the inferior wall. It's gotten rid of the gadolinium. And then in this anterolateral and inferolateral wall, you see endocardially based enhancement. And how do we describe it? How do we talk about it? Well, we basically divide the left ventricle into, by kind of like a pie, all right? Cutting out slices of a pie. And we look at the area of the late enhancement, here A, relative to the total area of the pie segment. So A plus B. And this is just quickly, after that study was performed, my goodness, is it accurate? These are some studies in an animal model where we have the late gadolinium enhancement in the inferior wall. You have the histopathology, and you can see all the infarct here. And then this is a corresponding SPECT image. And what's kind of was important to point out, if you look at this apical view, that's a pretty reasonable size infarct. You appreciate that on histopathology, but not necessarily with the radioisotope method. But let's go back 2 slides. How do we describe this and what does it mean, this percentage of late gadolinium enhancement in that area? So that's what Ray did back in the New England Journal. So down here on the x-axis, this is the percentage of late enhancement: 0, 1 to 25, 25 to 50, 50 to 75, 76 to 100%. Over here on the y-axis is those that improve contractility. This is in chronic ischemic heart disease, 6 months after successful coronary artery revascularization. So if you have a segment that is hypokinetic, akinetic, it has no late gadolinium enhancement, they have chronic ischemic heart disease, you do a percutaneous or an operative procedure, that segment has an 80% chance of improving contractility after that revascularization. Again, 6 months if it's successful. Now, if you have 1 to 25%, it drops to 60%, and then 26 to 50, it drops to 40%, and then beyond 50% of that wall being white with late gadolinium enhancement, there's very little chance of improvement in contractility. Now, interestingly, Ike Nagel's group in Berlin did sort of a follow-up with low-dose dobutamine, and they said, well, what if I've got folks that have 1 to 25 or 25 to 50% late gadolinium enhancement? I've got kind of a 50-50 chance that that segment's going to improve systolic thickening. So what they did is they administered low-dose dobutamine. I mean, one of the nice things about MR is you can do that, and this is looking at the same issue. So no late enhancement, 25%, 25 to 50. And what you see, this is the sensitivity and the specificity, these 2 bars here, for identifying functional recovery. And it's really at almost above 90%. So sometimes what we do, if we have more than 50% late enhancement, we really don't chase that. But if we have 25 to 50 and folks really want to know, we'll do low-dose dobutamine infusion. And this sort of gives you the reasons why we do that. This is just a quick example. Here is a patient with chronic ischemic heart disease. The septum is free of late enhancement. Here, there's near transmural enhancement, so we don't really have a question there, but the referring physicians, this is for coronary artery bypass grafting, they wanted to know with this wall, okay, this is not, transmural enhancement. This is kind of in the 25 to 50% range. And so here's the resting contractility, and then this is the contractility with low-dose dobutamine, and the amount of thickening one experiences during that low-dose dobutamine infusion is really equivalent to what the contractility will be at rest 6 months after successful revascularization. So that's how those two work. And then, we hear a lot about the term viability. We talk about viability a lot, and viability means different things depending upon the test we order. It could be cellular viability with PET scanning, FDG, there's thallium that's looking at cellular survival. What you're doing with late gadolinium, and then dobutamine is looking at contractile reserve. So if you're using echo, that's contractile reserve of the myocardial, the myocytes. What we're doing with late gadolinium enhancement is really looking at the scar. It's the opposite of being viable, right? And so that's how you want to think about this. Now, what happened after that is patients started to be scanned, and it's more prognosis studies were coming out, and we started to observe that not necessarily in ischemic cardiomyopathy, but in other forms of cardiomyopathy, the presence of late gadolinium enhancement was associated with a poor prognosis. And this was from Raymond Kwong. And here is a two-chamber view. Here's end diastole, one of the cine images, and end systole. So the contractility looks normal, but look at this late gadolinium enhancement in the anterior wall. And that's associated with a poor prognosis. So then other investigators said, well, hey, wait a minute. Why don't we quantify the amount of late enhancement relative to the entire left ventricle? So remember when we were doing those cine images and calculating volume? Well, you can get the late gadolinium enhancement in the same planes. And so this is sort of depicting that. And you can look at the scar relative to the total myocardial volume. And in patients with ischemic cardiomyopathy, what's been found and repeated over and over, going to start to remember this number. This is 13%, but it's going to be between 10% and 15% for all the rest of the conditions. That's kind of a magic number that is a threshold for a much increased risk of ventricular tachycardia, ventricular fibrillation, and then other untoward cardiovascular events. But this is how that is done. Now, not all late enhancement, as more cases have been performed, not all late enhancement is endocardially based. So here's a 27-year-old with chest pain and a positive troponin. And I want you to focus on the image on the right. This is, again, a three-chamber view. So here's the left atrium, the aorta. Look at the normal. There's no late enhancement in the anteroseptum. But look at this inferolateral wall. Now, the late enhancement, notice here, it's not endocardially based. It's epicardially based. And this is a pattern that we see with myocarditis. Now, other studies started to be performed, and we started to appreciate worldwide other patterns of late enhancement. And look at this one. It's not endocardially based, and it's not epicardially based. And we use simple terms in MR for this. This is mid-wall. And so there's mid-wall enhancement, just like this. Well, now, over the many years, there are many patterns of late gadolinium enhancement, and that's depicted in this cartoon. So here, most of the patterns that are endocardially based, that are regional and fit within sort of a territory of a coronary artery, those are associated with ischemic heart disease, whether they be a subendocardial or a transmural infarct. These other patterns are associated with all kinds of other disease processes. For example, here's sarcoid over here on the right. It's kind of splotchy. See all these little splotches everywhere? So that's sarcoid, things that we refer to Dr. Jordana Krohn. Here is a dilated cardiomyopathy with some mid-wall enhancement. This is myocarditis with the epicardial. Patients with pulmonary hypertension. Look at this thick RV wall here. and you see enhancement at these hinge points associated with elevations in pressure. Cardiac amyloid, that's an interesting pattern. Dr. Kershaw works in that area. And you see this diffuse enhancement all throughout the myocardium. And then look at this in hypertrophic cardiomyopathy. This is the septum. From here, the endocardial surface of the LV to the endocardial surface of the RV. And look at all that enhancement in the wall. So we're going to focus a little bit on hypertrophic cardiomyopathy. Does the presence of late enhancement in hypertrophic cardiomyopathy without ischemic heart disease, is that associated with events? So here are a series of short axis images, and then here's a 4-chamber view at end diastole. And look at this large, thick anteroseptum and septum, infroseptum. And here's at end systole, again, all that abnormal thickening. And then look at the late enhancement, all in that region of the septum. Well, in this particular patient population, you can look at these Kaplan-Meier curves, and whether we're looking at cumulative survival or risk of sudden death, the presence of that late gadolinium enhancement within in patients with hypertrophic cardiomyopathy is associated with those untoward outcomes. This is a separate study, but it's asking how much late gadolinium enhancement, how much late gadolinium enhancement. And this was 1,293 hypertrophic cardiomyopathy patients followed for 3 years, and they were really looking at sudden cardiac death. And I want you to notice this threshold marker. Here's that magic number again, 15%. So if you have none and less than 10%, those curves are almost equivalent. But once we get above that 10%, and again, this study is 15, you're getting in those low teens. And so we're finding that marker again in terms of amount of late gadolinium enhancement, very similar to those ischemic cardiomyopathy where we found 13%. And you're going to see that number come back over and over again in these different conditions. So much so, well, do we put a defibrillator in these patients? And this has now made it into guidelines. And so it's a 2A indication in patients with hypertrophic cardiomyopathy who have spontaneous non-sustained ventricular tachycardia or an abnormal blood pressure response with exercise, who also have additional sudden cardiac death risk modifiers. An ICD is reasonable if they're going to live longer than a year. And you can see that now one of those modifiers is delayed enhancement on MR. And so working with Mo Makié, we see a lot of these patients, and we're looking for that late gadolinium enhancement. Now, let's switch to dilated cardiomyopathy. So these are non-ischemic dilated cardiomyopathy. And we'll start first with a meta-analysis. And what you want to notice here is whether we're thinking about all events or cardiovascular mortality or VT or VF, the presence of late gadolinium enhancement is associated with all of those in dilated cardiomyopathy. Now, I want to bring up another point. We've talked about that teens, like 10% to 15%, but another important issue is where is the late gadolinium enhancement? And the point I want you to take away here, and this is true really for all these conditions, and especially we're going to talk about myocarditis in a minute. When the late enhancement is involving the anteroseptum and the infroseptum, and you look here in this forest plot, that is associated with future events. So the presence of septal late gadolinium enhancement and septal in combinations, like if you have just non-septal, not so much, but when it involves the septum, and all these see in all these little pictures down here, that's associated with future VT and VF. Now, there is a more recently described a desmoplakin mutation that also involves the left ventricle. So mutations in desmoplakin are the primary force transducer between cardiac desmosomes and intermediate filaments associated with ARVC. However, they're also present in a unique form of cardiomyopathy with a high prevalence of LV fibrosis. And the presence of any LV systolic dysfunction in desmosome cardiomyopathy with an LVEF less than 55%, particularly associated with late gadolinium enhancement, is also associated with VT and VF. So I want you to be aware of that. And notice when you have this condition, it does have that epicardial enhancement along the posterior wall. Now, I mentioned to you about non-gadolinium equivalents to late gadolinium enhancement, and that's called virtual native enhancement, VNE. And you're going to see more of this. And this is a paper from Circulation. I want you to just appreciate how accurate this looks. So this is a series of short axis images with the standard contrast, the late gadolinium enhancement. You see that all here in the walls. Look at the non-gadolinium enhanced equivalent. It's almost identical. And what we're starting to see emerge in large studies with, this was in hypertrophic cardiomyopathy, but also there's another paper recently in ischemic cardiomyopathy with thousands of patients. And you can see that the virtual native enhancement is looking to be very favorable. So that's why I was saying in the next 5 years, we may even move away a little bit from gadolinium administration. Now, I want to bring up another concept, and that's a different type of fibrosis that we might not be able to appreciate readily with late enhancement. So looking over here, this is again that short axis view. And here is the late gadolinium enhancement along the endocardial surface of the LV associated with myocardial infarction. And you can see this hematoxylin and eosin, this light pink, you see that fibrosis. But look over here. This is a dilated cardiomyopathy in a patient that's received anthracyclines. And you really don't appreciate any late gadolinium enhancement. But look in the wall. There's all of this interstitial fibrosis. And it really brings us to some of the pathophysiology of fibrosis. I mean, replacement fibrosis and scar, that's due to many of the myocytes dying. And then the collagen is secreted by the fibroblasts, these green in between, so that we have a scar here and our ventricle doesn't rupture. But there can also be fibrosis that accumulates in an interstitial pattern. And there can be processes that also get into that interstitial space. This is amyloid protein in this purple here. That not necessarily shows up super well with traditional late gadolinium enhancement. So what can we do? Well, that's going to take us back to how this whole technology works. And so I want you to think about the protons. Let's go back to those hydrogen protons. And outside of the magnet, I'm going to use my hands here, but the protons are all spinning in a random fashion, like here on the screen. What happens when we go up inside the bore of that machine? All of the protons line up in a specific orientation, every single one in your body. Then what happens is you take an FM radio wave, and what's interesting, in our geographic location, it is almost identical to the frequency of channel 6, CBS. You take that FM radio wave, you pass it through the target, and those protons tip their spins. Then after the FM radio wave has gone through, they go back to their original orientation. And what happens when they go back is they release energy. And in the wall of that scanner, or if we lay a piece of foam on the chest, there are antennae that pick up that energy, and that's how the picture's made. Well, how quickly they go back to their original orientation, the quick transverse plane activation, that's T2. That's a T2 time. It's a time in milliseconds. And then also, when the FM radio wave goes through, there's a winding, kind of like when I was a kid, we used to have tops, you'd spin them. So there's a winding, and then there's an unwinding. And that unwinding is the T1, and again in milliseconds. So we're going to use those properties, the T2 and the T1, to examine properties of the myocardium. And something I think you should remember, T2, the T2 time is pretty quick. And what it's doing is it's telling us how much water is in the heart muscle. And that water could be there because there's cells that are injured, the membranes have broken, there's water all around. It could be myocarditis, there's inflammation there. That's what T2 is. Very quick. T1 down here is really kind of a non-specific finding. what I mean by that, it's looking at the ratio of muscle cells to that interstitial space. And the way I always think about it is when we're 20 years old, about 80% of our myocardium of the ventricular volume is myocardial cells, and about 20%, so age 20, 20% is the extra stuff between them. When the T1 becomes elevated, there's something else there besides that ratio. There could be amyloid in that space. There could be water in that space. It's kind of like, I think of it as the CRP. It's not an inflammation marker, but it's like a non-specific thing. Something's kind of wrong. Now, why are these pictures in color? Why are these pictures in color? Well, they're in milliseconds. Each pixel is appropriate for a millisecond. And so there are many different changes in milliseconds, like the black and white images, like over here for late gadolinium enhancement, our eyes only see from bright white to dark black. If you're in a cave with no light, we see our eyes appreciate about 80 shades of gray. But color can be very useful when we have many different values for those milliseconds. And so that's why you're going to see these expressed as color maps. All right. Well, is that of any value beyond late gadolinium enhancement? And the answer is yes. So this is looking at 1,255 patients with valvular, ischemic, or non-ischemic cardiomyopathy. So all of those grouped, and looking at something we call the extracellular volume fraction. That's that fraction of stuff that's not the myocytes, that's in the myocardial volume. And after adjusting for all the other cardiovascular comorbidities, the EF, the presence of late gadolinium enhancement, what you see is that the more, in these bars here, the higher the extracellular volume fraction, the worse it is for mortality, heart failure hospitalizations, and importantly, in these border zones of infarcts associated with VT and VF. This is also just showing the same thing in a non-ischemic dilated cardiomyopathy. The higher that ECV is, the worse that you do. And this is just looking at across tertiles. It doesn't matter whether we look at all EF, all the EFs that are elevated, or the EFs that are below 30, more of that ECV, that number moving up, is associated with events. Now, how do we put this mapping stuff together and do a case? Let's work through one. It's a 74-year-old woman, past history of hypertension, diverticulitis, admitted after presenting to an outside hospital with pancytopenia, known to have recent diagnosis of amyloidocytic leukemia. She's undergone induction chemotherapy with cytarabine and daunorubicin. Cardiology is consulted for reduced EF and chest pain. Yesterday, she received additional untoward news of a myocardial infarction in her husband. She had several episodes of chest pain described as 8/10, sharp, non-radiating, lasting several minutes while at rest with spontaneous resolution, mild shortness of breath, no nausea, vomiting, or diaphoresis. Blood pressure was 210/110 on admission to the outside ED. Troponins were mildly elevated at this outside ED. EKG with non-specific changes, and the chest pain has resolved this morning. Now, you have some echo images before she started her chemotherapy. So here's an apical 3-chamber view, and you see the left ventricle here, normal wall motion, a little bit of aortic valve sclerosis. Here's the 2-chamber, normal wall motion. Now she comes to you, right? And look at this wall, all right? This anteroseptal wall here is akinetic, and we did strain, right? And you can see in these colors, see this blue line here? There's abnormal strain in that anterior wall. So what do? You send her over for an MRI. So here's the 3-chamber view, and look at this wall motion abnormality in the anteroseptum right here. It's akinetic. Same thing here in the mid-anterior wall. Now we do late gadolinium enhancement, and you're now experts in this. Do you appreciate any late gadolinium enhancement all the way around? No. Now this white here, that's pericardial fluid. So that's not late gadolinium enhancement. Now you get a T2 map. You've had education on that. Remember, they're color maps. And look, nice dark myocardium all the way around, right? All in this area of the wall motion abnormality, it's dark. See, we're characterizing the tissue. So what is going on with the patient? Well, is it an infarct? No, it's not. There's no regional anything. Is it adriamycin, viral, or bacterial? Well, those would be global hypokinesis. So it's regional. Nope, it's not that. Is it myocarditis? Well, it certainly isn't acute, and it's not chronic. We don't have late enhancement or. So what is this? Stress cardiomyopathy. This is a stress cardiomyopathy. And so what happened, managed the hypertension, initiated ACE, initiated carvedilol, and went on to receive the full chemo regimen. And you can see the complete recovery of function with echo. So that's how we put together the mapping thing. Now, quickly, let's turn to myocarditis. So myocarditis is kind of tricky. It's kind of tricky because we can have it acute with lots of water, inflammation, myocyte membranes breaking, or we can have the chronic part with all that fibrosis in there. So we have to put together getting lots of different images. We need the T1 maps, we need the T2 maps, we need the late gadolinium enhancement, we need the wall motion, we need a big complex picture to sort of sort out what to do. Well, what I want to leave you with in myocarditis, the same factors that we appreciated in hypertrophic cardiomyopathy, non-ischemic dilated cardiomyopathy, ischemic cardiomyopathy hold true here. Late gadolinium enhancement, if it's present, that's bad. If it's in the septum, that's bad. And if it's mid-wall, particularly involving the septum, these are the patients that experience sudden death when it's involving the septum and the anteroseptum. If it's confined to the infralateral and posterolateral wall, those are generally the folks that get better. And then we've used late gadolinium enhancement. Dr. Naveed Naz works through with this for athletes, especially those that experience SARS-CoV-2 or the vaccine associated. And I'm leaving this for you, this algorithm in your slide deck here that you can review. Images now can be acquired quickly. Images now can be acquired quickly. You can get some localizers. These are just blood flow measurements. You get the cine wall motion, and you can get the maps all in 8 to 12 minutes. So things are coming much quicker. Now I want to finish here and talk a little bit about implanted devices, because we deal with these patients that are at risk for sudden death. So the thing you want to take away from is that now with the proper precautions, we almost can scan anyone with an implanted device, but you have to take the right precautions. So this is a study in the New England Journal, 1,500 patients, non-conditional MR devices, non-conditional, 52% pacemaker dependent. The pacing mode was changed to asynchronous, and they followed, and there were virtually no long-term events in these. 9 people had some issue where they had to reset the particular device. And so generally, we're moving forward with doing these. There's an EP, and then the chest radiologists take a look at the leads and things like that. And we do have processes now for moving forward with these patients. But there is an issue with it, and that's this. And luckily, with John Grizzard's help and many others here on the radiology department, Dr. Fadl and Dr. Rezai and others, there's been a great accomplishment here. So this is before the device. So here's our 4-chamber view over here. Now this is an MR scan, and the problem is, see the device sits up here in the shoulder. It can cast an artifact that doesn't allow you to appreciate the LV myocardium. But now, with all of the help of the entire team, cardiologists and the radiologists working together, we now have what's called a wideband imaging technique. And Dr. Jordan here in biomedical engineering also heavily involved in this, and we don't have those artifacts anymore. But when you're ordering one of these, we need to know, because only right now at VCU, we have certain scanners with these devices. So this is for your handout, a series of when you would want to use and look for late gadolinium enhancement. It goes through all the conditions that we've talked about: dilated cardiomyopathies, ARVC, myocarditis, pericarditis, and goes through all that. And when you want to think about late gadolinium enhancement, what does it mean? It's just a nice review for you to keep with you when you get the slide deck. So in summary, cardiovascular magnetic resonance is excellent for characterizing myocardial tissue and determining the etiology of myocardial dysfunction in those with ischemic or non-ischemic cardiomyopathy. It's a little bit limited by access to the equipment for scanning. We're trying to work through that here, and we're working very hard. And it's attractive for addressing complex clinical and research questions. The thing I want you to think about is when it's telling us the why, like what's behind the LV dysfunction that we might see. The measurement of ejection fraction and assessment of regional wall motion, I mean, the choice of an imaging technique for EF could result in reclassification of a significant number of patients for ICD. So I didn't go through that data with you, but if you're ever unsure and you have an echo or a nuclear or MUGA study and you're wondering, this MR technique can very nicely quantify the volumes in the EF for you. And we went over why that is. An assessment of regional wall motion and anatomy is valuable to determine the etiology of cardiomyopathy or identify conditions. And we talked about mitral annular disjunction. And then late gadolinium enhancement in those with dilated cardiomyopathy, it occurs in about 30% of patients. And then we discussed the different patterns and the locations of LGE. And those are associated with adverse events. And variances in intensity of LGE can be predictive in variances of outcome. We talked about a little bit, we touched on mapping and that concept of extracellular volume fraction. It's an imaging method to identify an interstitial process that may not be readily apparent with late gadolinium enhancement, and it has added predictive value for death and hospitalization. Increased percentages are associated with increased events. ECVF may be elevated, remember, for other reasons than interstitial fibrosis. So if there's a lot of water in there, in that interstitial space between the myocytes, that can drive up your ECV acutely. And then also other things that invade that space, like cardiac amyloid. And then finally, here at VCU, very nicely, we have wonderful techniques for CMR exams to be implemented in patients with implanted devices, with the fact that we do need sort of the pre-screening to be completed by EP, and then we've got to have someone there to set some programming things. So if you have a defibrillator, we've got to turn off the ability to defibrillate the patient because you'll drain the battery if you don't. And then also we've got to set modes going into the scan, and then when patients come out of the scan, we've got to have those modes reset. So I want to thank you. We tried to do sort of a whirlwind tour on this, and the objective was to try to help with a little bit of understanding behind the data and why they're showing these particular patterns, and happy to answer any questions.
Thank you, Dr. Hundley. That was a great overview of the utility of MRI in cardiomyopathies, particularly in risk prediction, certain cardiac death. I have a question, and this was an extension of what you were alluding to about the acute and chronic phase, especially in myocarditis patients of the late gadolinium enhancement. I've always wondered, when we see a myocarditis patient, we get an MRI, we see that they have about 30% or 40% of scar, we know that their EF is down, and I'm not exactly sure what to make of that late gadolinium enhancement, which you alluded to. It could be from acute inflammation and acute water buildup, and they could go on to develop scar process that could also result in LGE. Do you think, like in terms of progression, do you think, is there any utility in like repeat MRI in these patients? Do you think there's going to be a drastic change? It's very important for risk prediction. So how would you approach LGE in the acute setting? Do you recommend like a repeat follow-up and see what the percentage is, or do you think there'll be any change? Can you comment on that?
Yeah, Rahul, that's a great question. You know, for all of these different disease processes, we didn't really review when do you get a test. And whether we're describing an acute infarct or myocarditis or even a chronic process, the fact that the late gadolinium enhancement shows and reflects both water as well as scar tissue, and then also the T1 and T2 values, they're constantly evolving and changing over time. For example, in an infarct, sort of right away, there's an increase in water present within the first day or so, then it goes away, then it comes back at about 6 days out, and then it goes away again. And so at about 14 days, you start to see sort of the stabilization of the scarred area. So same thing in myocarditis. So it's going to depend, you know, what you're going to get in the acute time windows, very acute, is lots of late gadolinium enhancement, T1 up, T2 up. Then you wait a couple days and the late gadolinium enhancement still going to be present. T1 is going to be abnormal, but T2 will be falling. And then a couple more days out, the T2 comes back. The late gadolinium enhancement is still continuing to wane, and the T1. And then several weeks out, you have sort of the firm scar. The T1 in the scarred area will be abnormal, but not in the other areas if there's no concomitant disease process. The T2 will have gone back to normal, and you'll have sort of the scar of the late gadolinium enhancement. So you have a great question. And then clinically, once you're at that 14-day time point, assuming no intermittent new events, then you're going to want to know, well, could that late gadolinium enhancement either go away or shrink further? Meaning, is there still water sitting there causing some of that process, or is it really going to fibrose and be a firm scar? And that depends on the disease process that we are evaluating. And so you just, depending upon the clinical situation, very often you do have a follow-up exam to look for, has the original process become a little bit more quiet, or has it aggravated subclinically, and we want to be aware of that, or has another new process occurred? So it's a complicated, it's a great question. It's a little bit complicated because it depends on the pattern of late gadolinium enhancement and what we've decided is the disease process that's ongoing. And there'd be different algorithms for whether it's sarcoidosis versus amyloid versus an infarct or versus myocarditis. It's a great question.
Right. Thank you, Dr. Hundley. We have time for a couple of questions in the chat. Jeff Kolominski, one of our cardiology fellows, he asked, in regards to risk stratification of certain cardiac death, the ejection fraction has long-term been the major determinant for ICD implantation. Are there any ongoing studies to evaluate how LGE or other CMR measures may add or perhaps be seen as equivalent to EF as a major indication for primary prevention ICDs?
Yeah, great question, Jeff. So, you know, below 35%, we're going to, if it's continuous, and depending upon, you know, maybe the etiology a little bit, but you'll have a defibrillator. So lots of gadolinium enhancement versus not so much, you know, it's really going to depend on the EF factor. What the studies are evaluating now is, what do we do with an EF from 35 to 65? And that is ongoing for different disease processes. What we do know is for hypertrophic cardiomyopathy, which often has a EF above 35%, is that late gadolinium enhancement threshold is a 2A indication for going ahead and moving forward with defibrillator placement. For other disease processes, yes, those studies are ongoing right now, and we're going to try to determine, you know, moving forward, absent all other criteria that may indicate the need for a defibrillator, what is the prognostic utility of that late enhancement?
Sounds good. There is one more question from Dr. Trankel. He asks, great talk. Thank you for going through this data. Do you have any predictions of how and when machine learning or AI might start to work its way into the clinical space for prognostication in the CMR lab?
Yeah, great question, Corey. My thinking on this is that it probably, where it's being worked on in cardiovascular a lot is with echo, because there are so many echocardiograms performed. But where it's struggling is where you don't have beautiful pictures. Versus in the world of MR, you have beautiful pictures, but there's just not that many of them worldwide. And so, not sure. Will it become a value? I think yes. Will it be implemented? Yes. The time frame for it, not certain just yet. But certainly, if a computer could read the cine images, which they can, we already have drawing algorithms that do that actually quite well, could evaluate the T1 maps, evaluate the T2 maps, evaluate the late gadolinium enhancement, and then integrate and come out with probabilities of what the patient has, particularly once that is integrated with the information obtained from natural language processing in the electronic health record. I think it's going to become very valuable. I think what the role of the physicians will be in that set of circumstances is going to be to sort of review and double check and all that kind of thing. I think there'll always still be a person involved. The other thing that you perform these and know, one thing is when these cardiac studies are ordered, is there something in the heart? But is there also something in the pericardium? Is there something in the lungs? Is there something in other components of the images? And how all of the AI will be worked into those components, et cetera, I think it remains to be seen. But will we, in the next 20 years, will that become an integral part of what we're doing? The answer is yes, but exactly when, not sure. I think the capabilities with MR are higher because the images are much more clear, and that we don't really struggle with that. In the world of echocardiography, I think the challenge is you've got a lot of images that are imperfect, and that's introduces some variance, and it makes it a little bit tougher for some of those algorithms to work on all patients. Great question.
All right, I think we're at time at 8:30. Thank you, Dr. Hundley. It was a fascinating talk. Thank you for taking the time to answer our questions as well. Yeah. If anyone has any further questions, please email either me or Dan and Winston, and we'll forward them to Dr. Hundley. And as I said in the introduction, the code for CME, please text to 804-625-4041. And with that, we conclude our grand rounds for this week. Thank you so much for attending. Thank you for your time. Thank you again, Dr. Hundley.
Thanks, everyone. Have a good day.